Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today our topic of discussion is about AIDS, acquired immunodeficiency syndrome, and its association with eyes. The different diseases which are happening in the patient of AIDS, HIV positive. Especially we will talk today about the retinitis caused by cytomegalovirus. Its different causes, its investigations, examination, and possible treatment. This is the fundus photograph of a patient HIV positive who has got cytomegalovirus retinitis. Here you can see that along infratemporal arcade, along the blood vessels emerging from the disc, there is retinitis, inflammation of the retina along the blood vessels, and there are also hemorrhages. And if we see the other photograph, which is giving a larger view, you can see that only the posterior area, posterior pole of the retina is involved. This disease is not yet encroaching the periphery, and mostly it is confined to the posterior pole, and to some extent it is also involving the macula, the central area of the vision. To some extent that is also involved. So this is an active disease. You can see that the retinitis over there, white lesions, and inflammation in the retina, and the hemorrhages you can see along the discs and along the infratemporal vascular arcades. Along the vessels it is going on. See the OCT of the macula, the central area of the retina, where 90% of the vision is. In this photograph, it is shown by arrow, there is subretinal fluid. And all this is going on because of this infection and inflammation which is in the eye, that is also involving the central area of the eye, that is macula. Just in the arrow it is shown the darker area, how it is elevated, and there is subretinal fluid. Another angle, same patient. Here you can see that inflammation, the whitening, the retinitis of the posterior pole is going along the blood vessels, and you can say that it is going up to mid-periphery, not in the periphery. Yes, it is still going slightly outside the macular area, that we can say almost to the mid-periphery, but still the peripheral areas are spared, as we have shown earlier, that basically it is a posterior pole disease. The fundus photograph, when these patients are treated, after the treatment with antiviral medication, which we will discuss later on, this is the condition that the lesion remains over there, but it is no more that much active. It develops whitening over there, and the retina becomes thin at those areas, and it develops hemorrhages settle down, and later on they can develop holes over there. So these patients are very much prone to retinal detachment. So this is a photograph where we can say that if not totally healed, the disease is settling down. It is no more that much inflamed. The disease, because of the antiviral treatment, it is now settling down, and the hemorrhages are also getting lesser. And the one thing about this I wanted to say, that in cytomegalovirus we are having very good view of the retina in the first photograph and even in this resolving stage. The reason is, in cytomegalovirus associated retinitis, there is minimal vitritis. There is no much active cells in the vitreous. That's why we are having very good crystal clear view over there. These patients, we also go for the fundus fluorescein angiography. The dye is injected, and then the photographs of the fundus of the retina are taken. This is arteriovenous phase. Here you can see that hyperfluorescence along the blood vessels, where the lesion is, we can see over there. And along with this, the darker area, the black areas which are there, are basically hypofluorescent because of the blocked fluorescence due to hemorrhages over there. So the hemorrhages, number one, and number two, the vasculitis element, which is decreasing the perfusion also over there, they are both contributing to the hypofluorescence. So this is arteriovenous phase, and we can see the manifestations of the cytomegalovirus, how it is damaging. Fundus fluorescein angiography. Here again we can see the dark areas, the dark patches, which is hypofluorescent areas due to the blockage of the fluorescence. Yes, this is another fundus fluorescein angiography photograph. Talk about cytomegalovirus, it belongs to the same family as herpes virus family, and this especially gets activated when due to the HIV or AIDS, the patient's immunity is suppressed. So through blood, through the hematogenous route, it goes into the retina, and over there it causes the full thickness retinal necrosis. It goes into the retinal cells and replicates over there and causes necrosis and scarring and thinning and retinal holes, and these things ultimately take to the retinal detachment. But after the use of antiviral therapy, its incidence and its occurrence has decreased substantially. Well, if we talk about the types of cytomegalovirus retinitis, it may be indolent, it may be frost branch angiitis, but especially talking about this case, this is a relatively aggressive pattern, and we call it fulminant type of cytomegalovirus, in which the infection, the inflammation, and this retinitis is along the blood vessels like brush fire, and they even encroach the retina, which is characteristically shown in this photograph. Talk about the treatment. These patients need a team effort. The ophthalmologist and infectious disease department, they both have to treat together this patient. These patients need intravenous antiviral therapy, that we can say ganciclovir is a good option, and along with it intravitreal injections of ganciclovir, that is the dose is 2.5 milligram into 0.1 ml dose. They need it regularly, and if IV injections cannot be given, then oral ganciclovir is an option also. But intravitreal injections are very important in its treatment. The other thing is that these patients, when going systemically antiviral therapy, they need regularly renal function tests to see the renal toxicity. That's very important. So in these patients, HIV patients who have CD4 value, it should be regularly done. And if CD4 cells are less than, we can say that 50 cells per cubic millimeter, they are less than that, then these patients are the genuine candidates for regular screening for cytomegalovirus retinitis. The reason is, when this disease starts, it is usually not causing significant changes in the vision. So regular screening, especially in this bracket of the patients whose CD4 value is less than 50 cells per cubic millimeter, that's very important. During the course of the treatment, fundus photographs should be taken regularly to monitor the treatment success and modify it, alter it, and because the retina develops thinning, scarring, holes, as I mentioned earlier, so maybe these people may need vitrectomy for the retinal detachment, which may develop later on. So regular monitoring of these patients by fundus photographs is very important. We talk about the treatment duration. That is very important. The treatment should be continued unless and until there is a lesion over there, the retinal activity and the inflammation has settled down over there. So it should be continued. And the second most important thing is that the physician, as I mentioned earlier, the eye doctor and infectious disease department both go together. So they should keep an eye on the CD4 cells. If the CD4 cells are good, more than 100 per microliter, this is a very good indicator to stop the treatment. This is just basic the guidelines, how long we can continue the treatment. So when we talk about the cytomegalovirus, different zones have been made over there, especially when this lesion is in 1 disc diameter from the disc or 2 disc diameters from the fovea, we call it zone 1. If it is from zone 1 to the vortex ampullae veins over there, we call it zone 2. And from onwards from there, it is zone 3. So this patient, which we have seen today the case, it is basically involving zone 1 and fulminant type of cytomegalovirus retinitis. Yes. Apart from this, the diagnosis, if we want to go for lab works, we can take aqueous tap from the anterior chamber or vitreous tap, and we can do PCR test on this. The second most important thing is also we should go for the syphilis and quantiferon and keep other viral infections in mind. Particularly, while treating cytomegalovirus, we should differentiate it from the acute retinal necrosis. Reason is, as I discussed in my earlier videos, that acute retinal necrosis basically involves the peripheral areas, while cytomegalovirus involves the central lesion as shown in this video. One more thing is that in acute retinal necrosis, the element of vitritis is quite high. But in this, you can see that cytomegalovirus, the vitritis is minimal. And at the last, I will stress again upon the importance of screening of the HIV or AIDS patient whose CD4 value is less than 50 cells per cubic millimeter. They should go for the screening regularly, at least 3 months. Monthly they should go for the screening, because this cytomegalovirus, as I mentioned earlier, initially it is asymptomatic. And I hope this video will be beneficial to my respected and honorable audience in their clinical practice, and I want to thank them for their attendance and attention. Thank you.